It's a privilege to be here. I nearly didn't make it. I had to zoom in because I forgot my wife is on call, but I missed the last conference, so I was like, definitely have to come in. So I'm quite glad that both Simon and Marta have talked about rare disease and the importance of having expert centers, because when I was a medical student, and I'm sure a lot of the doctors in here will remember this, one of the things that people teach you is that is a saying that if you hear hoofbeats, you should think of horses and not zebras. But actually, and what that means is common things are common, which is true, but to a certain extent, because what we're talking about today is really rare disease and learning patterns, and doctors need to recognize these patterns to be able to pick up that 1 in a million patient who's got something rare. And as Christian has just mentioned, I coordinate this meeting, which maybe patients aren't aware about, but we talk a lot about these rare tumors in this meeting. And I'm just going to give you a bit of a backdrop as to how it started and where we are now. So before I start, just some facts. Brain tumors in children are rare compared to adults. This is just a graph from Cancer Research UK talking about brain tumors in general. And you can see that the incidence in children, so the curves that you look at in children, it's something like, it's much less compared to adults, basically. You're talking about 50 per million at the most. Sorry, not 50 per million, 5 per million at the most, because that's the line. And in adults, you're talking about 50 to 60 per 100,000, sorry. And you can see that the incidence rate's completely different. And this is a study that looked at the location of brain tumors in basically people who've got brain tumors. And the top is children, and the bottom is adults. And if you just focus on this bit, this is pituitary and craniopharyngeal duct, which is really the two tumors you've been hearing about, so pituitary adenomas and craniopharyngiomas. By no means, these aren't the only tumors that affect this area. But if you look at the incidence, in children, it's 0.15 per 100,000, and in adults, it's 10 times more. Yeah, so we're talking about a very rare disease. In adults, it's not common, but in children, it's even rarer. So Professor Kolmanitz has already talked about this case. I think this is the same case. So this is the boy with a prolactinoma who had a very significant medical family history. He presented about 11 to 12 years of age, was very resistant to medical treatment, had lots of surgery, and then finally had radiotherapy. And actually part of his treatment was done at the Children's Hospital of Philadelphia. And at the end of this whole course, and we've kind of lost contact with him because I think they're now in America, he landed up blind, he had a stroke, he had complete pituitary hormone deficiencies, his hypothalamus was damaged, so he had things like obesity and all the other side effects. And this is really, I'm using this as a case for change, really, just to illustrate what happens in these really rare tumors in these patients and how difficult it is to manage them, and which is why we kind of need these expert specialist centers. This is another chart, which was really, I think it's still unpublished. Christine, you might correct me, but it was done by a neurosurgeon based in Liverpool. And what she did was she sent out 8 cases to neurosurgeons all around the world with their MRIs and their case histories, and basically asked them, what would you do neurosurgically with this case? And you can see that actually it was a bit of potluck, what people would do depending on the center you were in. And the way you treat a certain MRI appearance would be completely different. Some people aspirate the cyst, some people would do 2 steps. They would actually try and decompress the brain and then think about doing a resection. Some would do a resection of the tumor straight up. So it is a bit of a luck of the draw depending on where you are, and this is why we need to think about having a specialist center where the surgeons and the oncologists and the endocrinologists who manage these patients are very used to it and see a lot of these cases. So, the title of my talk is really the Hypothalamo-Pituitary Axis Tumor Advisory Group, who I've inherited from Helen. And it's now an international multidisciplinary group. It was first mooted actually in 2010, when there was an idea of having a national virtual multidisciplinary team meeting. And it was really these 3 centers that started it off, so Great Ormond Street and University College Hospital, Liverpool and Manchester, and partially because these are the 3 centers that probably have the biggest volume of neurosurgical cases in the pediatric setting. The initial HPAT group focused on craniopharyngiomas, which you've already heard about, a really rare pituitary hypothalamic tumor in children. And there was a proposal that was put to the NHS England National Commissioning Group to basically say, can you fund this? Can you commission this? And as part of this, there was the idea of centralization, which is a very difficult word to some teams, really, talking about specialist centers and bringing these cases, make them come to all, basically a couple of units, or sorry, not a couple of units, a few units across the country. And people are quite resistant to that sometimes because they feel they've been operating on these cases for a long time. So the first pilot meeting was actually in 2011. Across the year, only 8 cases were discussed and 4 meetings, over 4 meetings. And this was really a pilot to prove the point that we needed this meeting. And there was a proposal to pump prime the meeting. And in 2013, the meetings became monthly. But unfortunately, the National Commissioning Group decided that funding was too expensive, and really this was an interest group rather than a proper multidisciplinary advisory group. And the advice was really for these complex patients to refer to the local adult pituitary service, because as you've seen, there are already for adults pituitary specialist units where they discuss these complex cases. And the discussion was to refer them to these adult services who generally don't actually discuss children. Around the same time, Helen Dr. Spadea started this big effort to develop these guidelines. And the background, the idea behind these guidelines was to provide evidence that actually we do need these specialist centers. And Professor Corbinitz has already indicated one of the guidelines and a few more that have actually come out as well at the same time. So where are we now? So 2011, that's where we started. This is 2023, and you can see that over time, the number of centers participating has gone up. At meetings, generally on average, we get about 12 to 13 centers coming. This is the COVID-19 period, and you can see that actually, because we were virtual, we never really lost participation. So it's really useful to be virtual. And we started off with 3 to 4 centers, and now we've got 23 centers who come to this meeting. Obviously not everyone at the same time, but they do come. And the meeting has become international sometimes. People have heard about this meeting partially because all of us in our big units have actually got fellows who come and learn from us. And then they go back to their home countries and tell their colleagues that actually this is a meeting that exists to discuss these cases. And we have to start thinking actually about how we, in terms of capacity, how we accommodate some of our colleagues from across the world. And we do learn from them as well, so it'd be a bit of shame to cut them out. The number of cases, as you can see, we started with 8, and now in a year we kind of discuss anywhere between 40 to 50 cases. We now hold a meeting once a month, and we discuss about 6 cases per meeting, and it runs for 1.5 hours. And like I say, virtual, so we've got participating centers from across the country and sometimes across the world. The meeting is very multidisciplinary. It's, as you can see, there's professionals from across the different specialists who are involved in the management of these tumors, so endocrinologists, neurosurgeons. We always have a neuroradiologist to look at the scans. We've got clinical oncologists who are the people who provide radiotherapy. We've got pediatric oncologists, we've got adult endocrinologists. So Marta comes to the meeting very usefully and advises us about some of these patients. And then we've got people from other professions as well. So we've got psychologists sometimes coming. And it's really useful to have this MDT contribution to the meeting because these patients are really complex. And it's not as straightforward as saying, oh, we just give medical treatment or we ask the neurosurgeon to cut it out, because there are side effects to all of that. This is just more recent data. So I took over this meeting in essentially 2019, 2020. And this is just looking at the outcomes of the different patients in the meeting. So way back in 2020, a lot of what we discussed, we didn't really change the management that was already decided for the patient. But over time, you can see that actually we're making more and more decisions, or we're advising on advising the local teams to do things slightly differently to what it originally was. So outputs, you've already heard about the pituitary adenoma guidelines, but actually alongside that, there have been other guidelines that have been developed. So Dr. Chaboni, she's in the audience. She was involved in this guideline for thickened pituitary stalks, which can be associated with different tumors, such as germinomas. The craniopharyngioma guideline is my baby, so that's come out last year. And then this is Professor Corbinet's guideline on pituitary adenomas. So it's really nice to have these guidelines out because they're evidence and consensus-based, and essentially we've got national agreement about what to do with these tumors. It's been supported by the Children Cancer and Leukemia Group and also the Royal College of Pediatrics, as well as supported by the British Society of Pediatric Endocrinology and Diabetes. And the one concept that comes out of all these guidelines is the concept of centralization, talking about the creation of specialist expert centers who manage a lot of these tumors, who have enough volume to have the experience in making very complex decisions for the children we see. So where are we now? Like I say, we have monthly meetings. It's a multidisciplinary meeting. At the moment, it's got what we call advisory group status, and what that means is we do advise. We advise about what to do with a patient that's been discussed at the meeting, but it's not compulsory that the clinicians discussing these patients follow what we're saying, essentially. Like I say, COVID was obviously a big issue about coming together physically to meet. So some of us used to gather in a room with other people zooming in. But actually now we're completely virtual. I think it's really helped in terms of participation and also with colleagues from across the world. Obviously a Zoom meeting, an EPIC, for people not familiar, is an electronic patient record system. So we're able to minute the meetings and send out the minutes to the different centers. There's now also a HPAT specialist interest group as part of the British Society of Pediatric Endocrinology and Diabetes, and we meet once a year. We've got a study day that's coming up later this month, so there's things developing there, and it's quite nice to have colleagues who are interested in this area come together to think about how we can improve things for our patients. The problem is these meetings are still unfunded. As I've said, they're not commissioned. We have administrative issues, so currently my secretary basically is the admin person for this meeting, and obviously if my secretary changes, you've got someone else new, and it's funded. She basically is my clinical secretary as well, and was Helen's clinical secretary, so she does my clinic letters, she does lots of other things alongside administrating this meeting. There's issues about capacity. Like I say, we discuss 6 cases in 1.5 hours, and quite often we overrun, and then we've got all these international cases coming in. And in terms of consultant time, so I'm paid for running these meetings, but I'm aware not all of my colleagues are in their job plans. So that can be an issue, and we've got colleagues who can't come to the meeting because they've got other clinical commitments at the same time. This is just a quick word about the recent NHS England Children's Cancer Principal Treatment Centre requirements. So these are the specialist centres that treat all sorts of children's cancer. It does talk about having MDT meetings, including long-term effects from your tumour. It talks about close working between different specialties. It doesn't actually mention endocrinology in the kind of headline. It does mention it's further down in the small print almost. But it does talk about this regional working with the establishment of national clinical advisory panels. I mean, that does exist for some tumors. So there's another tumor called an ependymoma, which is not in the pituitary gland, but there are advisory panels for that. HPAT is an advisory panel, as it were, for pituitary tumors. So it talks, it is encouraged by this document. So to conclude, that's the same patient that I showed you at the beginning. Childhood pituitary tumors are really rarer than in adults. So for example, that particular tumor is 0.1 in a million children. In adults, it's about 10 to 100 times more. But it's important to realize that unlike adults, children are growing, they're developing, they need to go through puberty, they're developing cognitively, their brains are still growing, and therefore they have different needs to what our adult endocrinology, neuro-oncology, neurosurgeons see. It's often not recognized that pituitary tumors are really a form of essentially tumors. So some areas, they don't discuss these cases in their neuro-oncology meetings. Brain tumors are funny because even though they can be benign they're classed as childhood cancer, so they're not always malignant in the sense that they don't always spread, but brain tumors are a bit unique because of the location. It can cause lots of different effects, so it's kind of recognized as a childhood cancer, but some of these pituitary tumors are not sometimes. And again, centralization of care is really needed to develop this sort of expertise, and there really needs to be a national advisory group like HPAT to support these decisions. We've got lots of centers participating, but also not every center in the UK comes to the meeting. And the last question is, if you're a patient, parent of a patient, where would you want your child treated? That's it.